You should be on soon. You should be on soon.
Cool, just let me know when to start.
Okay. Good morning, web shadowers. Welcome to week 7. We would like to thank you all for attending our session this morning. Today, we have the pleasure of hosting the wonderful Dr. Mittal again, a family physician.
As always, please remember that the Google form will be posted in the comments and on our Instagram bio at the end. With that being said, Dr. Mittal, you may start when you're ready.
Hi, everyone. Thanks for coming. And thank you to my hosts. I don't actually see the live coming up on YouTube yet on your guys' page. So if questions come up, just I guess put them in the chat for now, and I'll just keep refreshing and see if that comes up. So do we have people on? Do we know?
Yeah, we do.
Okay, cool. All right, let me share my screen then. All right, am I showing up?
Yes.
All right, perfect. All right, I'm gonna go over diabetes today in a number of different scenarios, kind of like I did on my last talk, like chest pain. And there's a few reasons I'm doing this. One, it's such a relevant topic, as I'm sure many of you are aware. I mean, you're going to see, as a physician, diabetes, and in every field you work in, you're going to come across it, and you're going to be dealing with it in some regard. So it is a very prevalent disease that you're just going to see. Number two, I just enjoy doing this a lot. Diabetes is one of the disease processes that I really enjoy treating. And number three, there's some aspects of this that I really wanted to share with you guys. About your role as a pre-med and why something or some of the things, a lot of things that you're doing right now are very relevant to, to medicine, and why this will be helpful for you in the future. So let's get started. Some background information on me. So I went to undergrad at UC Irvine here in Southern California. My major was bio. I graduated in 2013. I went straight through college to med school after that. Did my medical school, an osteopathic school, Turo, up in Northern California. I did my rotations down in Southern California at a county hospital. Completed my family medicine residency over at Baylor Scott and White in Austin, Texas, and now currently working for Kaiser Permanente in Southern California. And some disclosures that I need to read out. So these cases are examples only. There's no real patient information on here. I'm purely talking about education. This does not reflect the positions of my medical school residency or my current hospital of employment. How I talk about these cases is about how I work things up and I approach these scenarios. It doesn't necessarily reflect the standard of practice or different board specialty recommendations. I don't have any financial incentives or conflicts of interest with this presentation. Okay, so objectives. As I said on my last talk, I like to keep things really casual, and I really don't want this to become a lecture on pathophysiology. Obviously, I'm going to go over some basics of that, but I want to keep this as close to actual shadowing as though you were with me in person as possible. So we're going to go over a few things, just the very bare bone basics of the pathophysiology of diabetes, some of the long-term consequences that happen with diabetes, how to assess and treat diabetes in different scenarios, and how to communicate with patients, which is a big one for this. So what is diabetes? We'll talk about it in the traditional sense, type 1 and type 2. Type 1, we talk about the destruction of beta cells in the pancreas. The beta cells are what produce insulin. So their destruction means you have minimal to no insulin. You typically hear about type 1 diabetes in children. And insulin is what regulates blood sugar. It helps bring blood sugar into cells. Versus type 2 diabetes, which is kind of acquired. You hear about it more in adults. It can be, some aspect of peripheral insulin resistance, impaired glucose regulation. It can sometimes progress into type 1. And there are different things like type 1.5 There are other terms that, as the knowledge and research on diabetes progresses, that we're changing how we view some of these things. But in the traditional sense, it's just type 1 and type 2. So that's what I'm gonna focus primarily on type 2 during this talk. If I have time, I'm gonna give a quick example at the end of type 1, but my slides are pretty much focused on type 2. So we're going to talk about a little bit about the different types of medications, insulin, and whatnot. I don't want to get into, there's so many. And so I'm going to touch on, highlight on that, but that's not really the point of what I want to talk about today. We talk about, how many times is someone going to check their blood sugars if they have diabetes? And that's important because, if you're sticking yourself with a needle and poking yourself, 4 times a day versus once a day or a few times a week, that plays an important role in, someone's lifestyle. If you think about non-anatomical issues, stress, sleep, finances, resources, et cetera, and how that plays a role in diabetes care. So all really important as well. The thing about diabetes is it's marathon. It's for life. Once someone gets a diagnosis of diabetes, it never goes away. You will never not have diabetes once you had it. Now, it can be controlled. You can get off medication. We can call it diet-controlled diabetes. But again, that formal diagnosis of diabetes will always be there. So it does have a lot of long-term consequences, such as cardiovascular disease. People with diabetes have significantly increased risk for things like heart attack and stroke. And again, I will get into that a little bit later. Eye problems, kidney problems, peripheral nerve problems, feet problems, infections, electrolyte abnormalities. I mean, there's so much that you're at risk for with diabetes. So, when we're in primary care, not only is it our job to help control diabetes and help people, be under control and get their levels down and minimize that risk, but also to hopefully prevent someone from getting there. Let's say someone is in the pre-diabetes range for their blood sugar. We don't want them to actually get to diabetes. So it's a big thing that we deal with in primary care. And as I mentioned before, there's going to be some aspects of what you're doing in the pre-med stage of your life that come into play with diabetes care. But hopefully I can give some examples and show you why, it's good to pay attention to your classes here in college, because it does form the basis for your knowledge that moving forward in ways that you just don't even realize yet. So let's go over a couple of cases. So, and before I do that, any questions? Let me go through the chat and see if there's anything here. Lots of good morning everyone. No, I don't see anything too much. All right, let's jump into it. So diabetes in the clinic. All right, so we have a 50-year-old Hispanic, Spanish-speaking male with a past medical history of high blood pressure or hypertension, obesity, and a 5-year history of diabetes type 2. Presents for follow-up for his diabetes after not being seen in clinic for 1 year. So there's a number of things that I'm going to talk about before I and what I think about before I even go in the room. And we're going to kind of do a pseudo role play type thing of some of the questions that I would ask the patient when I go in the room and their responses, so you can kind of see what we're talking about. And there's going to be a lot that we're going to go over just now. And this is going to be in the outpatient clinic setting. And keep in mind that, in primary care, there's a time crunch. And I'm sure you can go back to my other video and see some of the things that I talk about why the time crunch is important. But you have 15 minutes, 15 to 20 minutes to do this visit. So it's quick, it goes fast. So we'll try and emulate that a little bit. The nursing note, again, before I go in the room, says he's taking his metformin, 1,000 milligrams BID, or that means twice a day. He had repeat labs on a few days ago for the first time in the last year. He states that his vision is a bit blurry at night in the last year. He's been getting some intermittent tingling in his feet over the last few months, and his urine recently has been foamy. So we'll get into all of that. So before I go into the room, what do I look at? What do I consider? Well, ignore the red. I should have done it. I think where it comes in later, but we look at some of the labs first and foremost. One, what is your hemoglobin A1C? A hemoglobin A1C is a 3-month average of someone's blood sugars. So it helps us get an idea of how someone's diabetes is doing over the long term, not just relying on, blood sugar checks like on the spot that they're recording in their log. This gives us a bigger view, an overall picture of how their diabetes is doing. We look at their creatinine and GFR, and that's a measure of kidney function. We look at their electrolytes. We look at their lipid panel or their cholesterol levels to see, how that's doing as well. Urine microalbumin and protein creatinine ratio. I'll get into that a little bit later. And that has to do with kidney function as well. Are his vaccinations up to date? We talk about people geriatric, 65 and older, who need things like pneumonia shots. But if someone's younger than 65 and they have diabetes, well, they have a chronic condition, meaning they probably need some level of vaccinations prior to the age of 65 that someone their age without diabetes would not. So it is important to help, prevent things like pneumonia and other things, to make sure that their vaccinations are up to date. Diabetic foot exam. As I mentioned before, people that have diabetes and especially uncontrolled diabetes, that high blood sugar really does have the potential to impact people's feet, specifically the peripheral nerves in feet. And it sounds dramatic to say this, but we see this all the time. It's, you go with uncontrolled diabetes, you're not taking your medication, you start to lose feeling in your feet. Feet become numb. You walk around your house or your garden or whatever without shoes on. You step on a rock or you step on a nail. Then you don't feel that you had an injury. Then you don't know that you had an injury. So it gets infected. Then you get an ulcer. Then you don't even know you have an ulcer, as you can't get it checked. And then you get gangrene of your foot, and then you lose your foot. And then you have an amputation. Again, that sounds a little dramatic, but I'm telling you, that happens every single day. People come into the hospital all the time because they need amputations on their feet, because they just didn't take care of it. So going through a diabetic foot exam, the recommendation is once a year on average, is important to screen people for diabetic foot problems. Diabetic eye exam, same idea, is high blood sugars or uncontrolled diabetes does have the risk of impacting the small blood vessels in people's eye, and people can lose their vision. So in addition, someone may have glasses and they say, yeah, I have an ophthalmologist or I have an optometrist that I go to and I get my eyes checked once a year. But a diabetic eye exam is very different. It looks for diabetic changes in the eye specifically. So a lot of clinics, or if your clinic doesn't, you have an ophthalmologist or an eye doctor, consultant that will help you do these eye exams for patients. So we do these screenings, once a year as well, to make sure that people are not losing their vision. Have they ever seen a dietitian to help them, figure out what they're eating and what they're eating that may be helping them or that may be hurting them? We look at last year, and that goes along with kidney function as well. We look at the meds that they're on. We look at depression screening. People with a chronic condition, right? If you get diagnosed with this disease at the age of 50, I would hope ideally you have a good 30 to 40 more years to live. Imagine dealing with a chronic disease for 30, 40 years. That's tough. Chronic conditions, people run the risk of becoming depressed. And so we always have to screen people for depression with chronic conditions as well. It does play a role in how we take care of their diabetes. So these are some of the things that I look at before I go in the room. And, let's go over some of these labs. So this guy, his hemoglobin A1C is 10, and that's high. Generally, diabetes range A1C 6.5 is the level, the cutoff, where we say is diabetic. Most people we like below 7, in the 6.5, mid 6 ranges. If you're over the age of 65, we're a little more lenient with someone's A1C control. We say 7.5 to 8 range. That's okay if they're a little bit higher. And the reason is, if someone's A1C is low, and this is the same, we'll take a step back and say, this is the stuff that I'll tell my patients as well. So this is the same information that I'd be giving them, is I'm not trying to control your blood sugars and have you have low blood sugars, when you're 70. Low blood sugars and high blood sugars are both dangerous, but low blood sugars are far more dangerous than high blood sugars. I would rather have someone in the 200s than have blood sugars of 60. If you have a blood sugar of 60, you run the risk of you passing out and then you die. So again, it sounds dramatic, but that happens. Again, low blood sugars are far more dangerous than high blood sugars. So, someone who's 50, I'm not as worried about a blood sugar of 65, 70 as someone who's 70, 75 years old. So I'm a little more lenient, and generally everyone is a little more lenient with older patients with their A1C. So this guy's A1C is 10. That's pretty out of control. His kidney function, overall kidney function, creatinine looks like it's pretty good, 0.8. But his GFR, again, that's another value of how we measure kidney function, is 40. So that is labeled as chronic kidney disease, now stage 3. You go chronic kidney disease stage 1, 2, 3, 4, 5, and you're on dialysis. So stage 3, that's where a lot of people are. That's pretty low, and we definitely need to keep an eye on that. His electrolytes are normal, and that's a big one that I want to get into a little bit later. His lipid panel is high, and he has what's called a ASCVD risk score, and again, that's something that is a measure of someone's risk for things like heart attack and stroke, and we'll get into that a little bit later as well. His urine microalbumin and protein ratios are elevated, which means, like I said before, with the GFR being down, there is some level of kidney dysfunction. So I have my agenda. I'm looking at all these labs. I'm looking that he hasn't come in over a year, and I have an agenda, right? There's things that I want to get done. There's things that I want to do for him, and I have my expectations. But I'm sure he is, and as every patient does, they have their expectations of what they want to get done in their visit and what they want done for them as well. So you have to balance it, and it can be tough, especially in such a short time frame. So let's jump into when we go in the room. So some of the things that we talk about is what are these questions, and I'll talk about why I'm asking them and a sample response that a patient would give, and then what would be the plan for each. So I'd say, how are you doing? Oh, doctor, I'm doing good. Everything's doing well. I feel good. I'm just here to have my, check up on my diabetes. It's been a year, right? So, okay, well, he's doing well. So as I pull up their chart on the EMR and I'm getting everything ready and pulling everything up, I'll say, any questions or concerns before I get started? And that would give him a chance to tell me about what he told the nurse, that he's having some vision changes, he's having some tingling in his feet, he's having some foamy urine, things like that. So as I get ready to pull up everything and show him some of his results and explain what's going on, I'm giving him a chance to show me, tell me. He already told the nurse. Sometimes patients will tell the physician things that they won't tell the nurse, and sometimes they'll tell the nurse things that they won't tell the physician. So it's just getting an idea of what he's willing to tell me, and trying to build that rapport with a patient and build that relationship with a patient. Because again, if I don't have a good relationship with the patient, I might not be able to push my agenda of getting things under control. So he'll tell me about all those things. Also, tell me about your sugars. So what I would like to hear from someone is, how many times a day or week are they checking their sugars? What are their average sugars? I would follow up on that and say, so, how many times a week are you checking? What's your average? If someone says, oh, 125, I was like, well, I would say, what is your average in the morning if they're checking it multiple times a day? What are your averages before each meal, or if they're taking it 2 hours after their meal? What are they, what are they running? Are you still taking your metformin, right? If I see an A1C of 10, it may be that he's not taking his metformin. He told the nurse he was, but maybe if I ask him, he would say that he wasn't. Let's just go with this scenario that he said, yeah, taking it, 1,000 milligrams twice a day as I'm supposed to. I can look on my EMR and see that he's refilling those medications or picking up his refills at the appropriate time. So he's probably taking it. And I have to tell him about the problem in your feet. He says, yeah, I don't know. It's just, every so often I get this tingling and burning in my feet. It tends to go away by itself. Sometimes I have to rub my feet because I can't really feel them. And it's not all the time. It's just here and there. But it's only been in the last few months. I've never had that before. So I'm not quite sure what's going on. And that was when I would get into that discussion of what I just mentioned before about how uncontrolled blood sugars can affect the feet and why it's important. And at this point, I probably, or may not have told them that his A1C is 10 and that it's really out of control. But that's what I would talk about at that point. And that's where I would give my education to the patient about specifically the feet issue, the diabetic foot issue. Let me just talk about some of these questions as they're coming in. How does diabetes affect the peripheral nerves? Well, just high blood sugars can just affect and just damage these nerves. Did I learn Spanish? Well, Spanish is pretty good. It's okay, but you don't want to miss anything. This is an important aspect about primary care in any specialty. When you have someone that speaks a foreign language, if you are not comfortable being completely fluent, you should use a translator because things get missed and you don't want any level of miscommunication. It's not fair to you. It's not fair to the patient. What do the units on A1C lab numbers represent? Again, it's a 3-month average of someone's blood sugars. Let's see. Is it possible to revert a gangrene if it's caught early enough? It might be. If someone's getting that level of diabetic foot problems, we are generally managing their care with a podiatrist, a foot surgeon, as where they're the experts in this. So they would be taking over most of that care as well. Then yeah, when you have ulcers and things, controlling someone's diabetes is the big thing that you can help reverse those changes. Um, let's see, would you focus more on creatinine or GFR to determine the CKD? It's by the GFR. Um, okay, tell us about your vision. Yeah, doc, normally I do well, but I noticed that when I drive at night, things just get a little blurry. I haven't had any accidents. I haven't said any, had anything become a problem. It's just a little blurry. It's been over the last few months, and I know I never wear glasses usually, but maybe I need to go get my eyes checked. Can you place a referral for me? And then that's a pretty typical response I think I would get from that. So that's when I would talk about, hey, one of the things that we need to discuss is because you have diabetes, we need to make sure you get a diabetic eye exam because XYZ of what I mentioned before. Those high blood sugars or uncontrolled diabetes can damage the blood vessels in the eyes that can cause some level of vision loss. So we do want to screen for that. So I would say, we'll place a referral, to get your eyes checked. And specifically for me in my clinic, we do that in my primary care clinic. We'll do diabetic eye exams. So we can get that organized as well. Tell me about your urine problem. Well, I don't have a problem with my stream. I can urinate fine. It doesn't feel like I have an infection. It's just, there's a lot of bubbles that come up, I noticed, and that's just been happening recently. So we'll talk about kidney problems. My plan for each of these, I'm going to go into a little more detail a little bit later on another slide. We'll talk about how, again, as I mentioned, diabetes can affect the kidneys. And there are ways to mitigate the urine problem and the kidney disease with medication. There's something we have to manage with that, and I'll get into that in just a little bit. So I was like, let's talk about your labs. And that's when I'll show him everything. That's when I'll show him that there is some level of kidney dysfunction. I will say, there are some medications we should be talking about to help you, stabilize your kidney function. I would talk about his A1C and make sure that I try and emphasize, hey, this is not under control. This metformin may not be enough for what's going on your diabetes to help control this. We'll make sure there's no other symptoms like chest pain, shortness of breath, we call angina. You can revert to my other lecture that I did to talk about chest pain issues and make sure there's no issues with concern for heart attack on my end. What kind of exercise are you doing, right? If someone's doing all that they can and they have a fantastic diet and they're exercising and their blood sugars are still not controlled, well, at least I know that they're doing stuff on their end to help control their blood sugars. So I talk about exercise, and it's important for cardiovascular health and for diabetes that we talk about exercise. And what's important for exercise? We talk about cardio in a traditional sense. So what do we mean by cardio? We talk about any exercise that gets your heart rate elevated, and your heart rate elevation at two different levels. One, the heart rate elevation that you would get for something like a brisk walk versus the heart rate elevation you would get for something like running or jogging. So a mild to increase in heart rate elevation versus a high increase in heart rate elevation. That's what we mean by cardio. And there's only one statistic that we know that matters about cardiovascular health and cardio type exercise in the long term. There's only one statistic that matters. It's not that 10,000 steps a day. That doesn't mean anything. What we care about is how many minutes of cardio you do per week. That's the statistic that matters. So what are the recommendations? We would say 150 minutes a week, which isn't that much, of low intensity exercise like a brisk walk, or half of that, 75 minutes a week of high intensity exercise like jogging and running. Obviously, the more you can do, the better. That's great, but that's the minimum. That's what we would like people to do. And that's what's been shown to help reduce things like cardiovascular disease processes. Tell me about your diet. Who cooks? Is just this guy, as he's single, does he have a family? Is it him that cooks? His wife that cooks? Does he have two jobs? Is he never around to cook? Is even if his wife cooks, is he going to work at 4 a.m. and coming back at 9 p.m.? Is he eating all of his meals at work? Is he eating a lot of fast food? And how does that play a role into his uncontrolled diabetes? That can give you a really big clue. And that's something that, if it's abnormal, that's something you have to address with the patient. Obviously, things like avoiding too many fats, avoiding too many fast foods, avoiding bad carbohydrates. We don't want processed stuff like white bread. We want multi-grain bread, whole grains, things like that. Avoiding sugars, looking for sugar substitutions like Splenda, 0-calorie drinks, avoiding sodas, things like that. It's all things that you have to talk about. And there is a special point that I want to bring up about this is, I make it a point, I will never tell someone to not eat their ethnic foods. If I have someone who's Asian and they say they have a lot of rice in my diet, and I will never tell them, you can't eat rice anymore. If someone's A1C is really, really, really bad, I would say, okay, maybe we should cut back and cut it out for a few months until we get under control. But I want to make sure that people are eating their ethnic foods. If I have a Hispanic patient like this patient, I will never tell that patient, don't eat your ethnic foods, don't eat beans, don't eat rice, don't eat tortillas, whatever, right? That's not reasonable. They're going to tell you to shove off, right? The patient's going to be like, I'm not going to listen to you. I'm going to eat what I want. If you're going to tell them not to eat their ethnic food. So you have to learn how to, appreciate someone's cultural background and, know how that plays a role into their daily life. As I mentioned, this is a marathon. This is for the rest of his life. He's only 50. I'm hoping he will live for, till he's 80 or 90. You tell someone they're not going to eat their home cooked food for the next 30 years, they're never going to come back and see you again. And then you've lost the patient. And that's not what you want. So there's a lot that goes into that discussion about diet. Who do you live with, right? What's your support system? Dealing with diabetes, checking your blood sugar every day, remember to take your medications, in addition to managing your house and your finances and your job and your kids. It's hard. It's a lot. So who supports this guy? Who's there to help him out? Oftentimes, if they have a support system, I'll say, hey, bring in your wife, bring in your spouse, bring in your husband, bring in your son or daughter who takes care of you, bring them into your next visit so we can talk about it and have a family discussion. So that's important to get your support system involved as well. And what do you do for work? If someone is sitting at a desk all day, as opposed to someone who works in construction, is up on their feet and moving all day, and that gives you an idea of what their activity level is, and that can help you adjust your overall plan to care for this person's diabetes. So there's a lot to talk about here. Let me see. How would you treat a patient differently as a DO than an MD would? The same. I wouldn't do anything different. Is tingling neuropathy? Yes. Any benefit to non-fasting A1C? No, there's not. I get a fasting glucose, yes, but a fasting A1C, no. Any difference between how a DO and I did that. So a diabetic eye exam cannot be done by a regular ophthalmologist. It can, absolutely. It's just some systems like the one I work in, we do that in primary care, so we don't need to. Now, if we screen for it and find an abnormality, then I will send to ophthalmology. All right, let me keep going because I don't want to run out of time. So let's talk about his vital signs, right? His blood pressure looks fine, his heart rate looks fine, his oxygen saturation, respiratory rate look fine. He's obese, right? His BMI is 40. That's high, right? So that plays a part. His physical exam is totally fine. We'll do the diabetic foot exam, looking at what's called a monofilament test. You guys can look that up and see what that means. But we test it and we see that there's decreased proprioception and an abnormal monofilament findings on his diabetic foot exam. So there is some level of dysfunction here. Plan. So work on diet and exercise. So again, once I had delved into his diet and what his exercise regimen is, I make my recommendations. We would probably change his diabetic regimen. We may want to put him on insulin temporarily to help get his A1C down. Oral medications, they're not on average as effective for diabetes at the higher A1Cs. Once you get into the more 8-9 range, they work a little bit better. So when someone is very high, I don't know that I would necessarily start this guy at A1C of 10 on insulin, but if someone came in at 13 or 14, I would probably consider it and get them down to a more reasonable level over the course of 3 to 6 months, and then put them back on oral medications. I'll talk about insulin in the next case real quick, versus there are some injectables that you do once a week versus other pills. The diabetic foot exam, the diabetic eye exam, BP medication, and cholesterol medication. So that's what I'll talk about, some of those other things. Now, we talk about ACE inhibitors or blood pressure medications that are good for controlling blood pressure. His blood pressure was fine. There's two reasons why we start blood pressure medications in diabetics. One, obviously, to control blood pressure, which whatever. That's not a huge thing for me. The big benefit comes in is certain types of medications, again, ACE inhibitors, ARBs, ACEs and ARBs, they tend to help protect the kidneys against diabetic changes. So even if someone's blood pressure is good and under control, he has some wiggle room. I would probably start him on, or not probably, I would ideally see if I can start him, if he agrees, on a low dose blood pressure medication to help protect the kidneys against some level of diabetic kidney changes. These medications can impact electrolytes. So after I start him on this medication, I would need him to come back in a couple of weeks to recheck his labs to make sure his kidney function and his electrolytes aren't impacted by the medication that I started. So that is how I would deal with his level of kidney dysfunction. Is I would start that medication, and we would get into other things like how to avoid NSAIDs or anti-inflammatory things like ibuprofen and avoid things that can impact the kidneys at home. Cholesterol medication, similar to blood pressure medication, there's two big benefits. Obviously, helping to lower cholesterol levels overall, which is whatever, fine. Yeah, obviously we want people to have lower cholesterol levels, but the big benefit is lowering their risk for heart attack and stroke. Now, we talk about arterial plaques in the arteries. I'm sure you guys have heard that term before. Everyone has plaques in the arteries. It's like a kid, you're going to have some, even a 6-year-old might have some level of plaque in their arteries. The problem comes in is when we get older, especially moving into the geriatric range, 65 years and older, and especially people with chronic conditions like diabetes, those plaques, you have your wall of your artery and you have a plaque sitting here, that plaque can become unstable. And you run the risk of pieces of those plaques breaking off and traveling up the heart and bloodstreaming into the neck and causing things like heart attack or stroke. So the big benefit for me, long-term preventative medicine-wise, for starting a cholesterol medication is not just lowering cholesterol levels, but the big thing is they help stabilize those plaques and the cap on those plaques to help prevent pieces from breaking off and causing things like heart attack and stroke. And there's something I mentioned before, ASCVD. If you look at someone's ASCVD risk score, you can do that calculation based off labs, blood pressure, etc. You can look that up to help determine is someone at risk for this stuff over the course of the next 10 years or their lifetime, things like heart attack or stroke, and determine if you need a medium to high intensity statin or cholesterol medication based off their risk factors. So we would talk about that. Urine test. It's another way how we measure someone's diabetes. So the microalbumin, the urine test, even if the creatinine isn't showing major dysfunction, sometimes we can catch microscopic changes in the kidney by checking for microscopic protein in the urine by these urine tests to help determine, hey, there's some microalbuminuria, some microscopic protein in the urine, but the GFR and the creatinine is fine right now. Let's start a blood pressure medication now to help mitigate any potential further damages to the kidneys. So that's why we do some of these urine tests as well. And then we'll say follow-up time frame, right? If I'm starting someone on new medication, specifically insulin, I want to make sure that they understand it, how to use it. I'll get into insulin a little bit on the next case. But what's the follow-up? Well, I'm not going to wait another year for this guy. I'm probably going to see him back in a few weeks to a month. I'm not even going to wait 6 months for someone who's uncontrolled. I'm going to see them maybe back in 3 months with repeat labs, or repeat A1C to see how we're doing. Okay, that was a lot. Let's see. Let's answer some of these questions. Does diabetes play a role with the auditory system? Not as much as I would say the kidneys, the heart, things like that, but it affects everything, absolutely. In the context of ongoing obesity epidemic, do you see any pediatrics precursors with type 2? Yeah, that's a big problem. You see kids who are obese with type 2 diabetes all the time. It's tough. And I was going to get into pediatric stuff at the end if I have time. Let me see. Can type 1.5 diabetics take oral medication instead of insulin? Yes, they can. It gets a little tricky, but that is possible potentially depending on the patient as well. What type of changes would you have to make for their diet? Again, avoiding things like sugar, healthier carbs, decreasing portion size, smaller frequent meals, things like that. How often do you have to take urine tests? At least once a year, if not twice a year, depending on the level of dysfunction that they have. What factors contribute to having ASCVD, like high ASCVD risk score, which is the fact that you have diabetes in and of itself, cholesterol levels, are you a male, your age, are you treated for hypertension or high blood pressure, things like that. Can someone with diabetes live a long life if it's kept in check? Absolutely, 100%. And that's where primary care plays its big role. All right, let's keep going. Diabetes in the hospital. My last case, I went over diabetes in the ER. I wanted to do a hospital because, as I mentioned in my last lecture as family medicine, I can work in an urgent care, I can work in an ER, I can work in a clinic, I can work in the hospital. So I want to give you a little bit different perspective of how I would treat something in the hospital setting as a family medicine physician. So same idea. 50-year-old Hispanic, Spanish-speaking male with past medical history of high blood pressure, obesity, diabetes type 2 is admitted to the ICU for DKA. Okay, first, what is DKA? Diabetic ketoacidosis, life-threatening complication that can happen from diabetes, characterized by hyperglycemia or high blood sugar, relative insulin deficiency, ketoacidosis, and specifically, that's the big one, is anion gap metabolic acidosis. Acidotic, you think back to your GCAM, acid-induced state, things like that, ketones for those of you who are in OCHEM. These terms play a role. So as I mentioned, or I'm going to mention, the things that you're doing in college are important. Your general chemistry, your OCHEM, these terms, the basic foundation for the knowledge that you are forming here for medicine, it all comes back later. I'm not saying you're necessarily going to be doing chemical reactions as a physician. You're not. But knowing these terms and the work that you're doing now is important. It's a big pet peeve of mine. I hate when physicians tell people, "Oh, nothing you ever do in college is going to be relevant. You'll never use any of that again." That's totally and completely false. And I'm going to start giving you examples specifically in diabetes, and if I remember, other things as well as to why that's true. Excess sugar is broken down by the liver into ketones, and that's why you get this ketotic state. Some of the hallmark symptoms of DKA are malaise, fatigue, altered mental status. That's a big one. Nausea, vomiting, etc. Basics of an ER workup. Someone comes in with altered mental status. You may or may not know that they have a history of diabetes. They can't respond to your questions. They're totally altered. You have no idea what's going on. Their blood pressure is down. They're unstable. You're giving them fluids, you're running labs, and you're going to look for things like doing the calculation of their sodium, their chloride, their potassium, etc., bicarb, to look if they're in an acidotic state. You're going to know to diagnose DKA based off that and their glucose levels, etc. Basically, as I mentioned in my last lecture, as in the ER, if you're working there or someone's working in the ER, your goal is to determine someone needs to be admitted to the hospital, which this person does because he's in DKA, stabilize and admit. So I'm not going to get too much into the ER workup. I want to talk about the hospital setting. So you go to the ICU, you're going to go admit him. He's already there. Blood pressure is a little high. He's tachycardic. His heart rate is 110. Oxygen level's fine. He's breathing really fast. Could be another sign of DKA is their high respiratory rate. Again, he's obese. He's altered. He's not responding to your questions. The rest of the exam is fine. Pertinent labs, his glucose 578. It's really high. Electrolytes, sodium's a tad low. Chloride is low. That's supposed to just be CO2. Your bicarb level is 7. Your potassium is 3.1. Potassium's a hair low. One of the big things with potassium I want to mention is, I'm sure you all remember the term from GCAM and probably bio too, is that sodium potassium pump, right? You think, oh God, that sodium potassium pump. I hate that term, sodium potassium pump. I'm so sick of it. Well, it matters, right? I mentioned that insulin drives sugar from the bloodstream into the cells. Well, what does insulin also do while it does that process? It also takes potassium out of your bloodstream and into your cells. So you have this relative intracellular hyperkalemia and relative temporary extracellular hypokalemia. And why is potassium really important? Well, if you don't know that potassium, it can be low because you're giving all this insulin to lower his blood sugar levels, and this insulin drip that you've started in the ICU, your potassium comes down, and you don't know how to replace someone's potassium, and then they have an arrhythmia, and then they die. Again, that sounds dramatic, but that will happen. If you don't have that basic understanding of how potassium travels between cells, that sodium potassium pump and things like that, you will kill someone. Yes, there are protocols in place to help prevent that. Checking lab values, replace the hypokalemia protocol that with DKA in an EMR that we've set up because it's such a known thing. But you have to have this level of understanding as a physician and what you're doing now in GCAM and OCHEM, that you are forming the basis to know that, hey, I have to pay attention to potassium, and I have to know there are certain medications that shift potassium to different parts of the body and how that can impact someone's arrhythmia. So, this stuff is important that you're doing. So, always pay attention, never stop learning, and don't let anyone ever tell you that what you're doing in college isn't important to becoming a physician, because it is. You are forming that base knowledge. His anion gap, to keep going, is 25, so it's elevated. His ABG, arterial blood gas, it shows that he's acidotic. His pH is 7.18. Again, acidotic, again, these terms that you're learning right now as a pre-med are coming into play here. His creatinine's 1.6, so it's elevated. His GFR is down. His A1C in this scenario is 13.8, so he's really uncontrolled. His urine is showing tons of glucose and ketones in the urine. There's obviously more, but that is the pertinent labs that I wanted to talk about DKA. Treatment. This is very protocol driven. IV fluids, insulin drip. There are certain levels of potassium that you need to see before you can start an insulin drip. And if the potassium is too low, you need to replace that before you can do an insulin drip. Do you need to replace their glucose, right? You may be giving so much insulin that you lower their glucose into dangerous levels. Again, DKA comes with high hyperglycemia or high blood sugar levels, which is bad, which is dangerous. People can die from DKA. But if now you drop their blood sugar level to 40 and then they have a seizure or they go into a coma, well, that can be much worse. So again, knowing you have to give someone blood sugar for their DKA hyperglycemia state seems counterintuitive, but again, depends on what kind of medication you're giving, like an insulin drip, how frequently you're monitoring labs to measure their electrolytes, make sure you're not causing potassium problems. When do you start subcutaneous insulin when they're more stable, to make sure that you don't have a rebound of your DKA after coming off an insulin drip? There is about traditionally a 1 hour overlap that you do with your subcutaneous regular insulin that you would imagine people do at home with their insulin drip. So all of these things that you have to talk about, and ideally with your discharge and follow-up for this patient, once they're under control and once they're stable. Yeah, if I'm a hospitalist and I'm not working in the clinic, I'm not following this patient up myself. I don't know them. I may be sending them to someone who has no idea who they are. So I have to start them on medication that's going to be relevant for them. Do they even know how to use their medication or how to take their medication? Do they have that understanding? They may not see their follow-up visit with their primary or endocrinologist or whoever for weeks. So I need to make sure that they don't come back to me as a hospitalist going into DKA again or hypoglycemia because they don't know how to take their medications. That looks bad on me as a hospitalist. So you have to know that they understand their diabetes and their medication. So all that we talked about on the outpatient side in the clinic setting, you have to do that in the hospital as well to make sure that they know what they're doing. If they're insulin, do they understand and know how to take it? Do they know how to draw up their medication? If they're drawing up 10 times the amount of insulin that they were supposed to take because they don't know how to draw it up from the vial with the syringe, are they going to overdose themselves and then end up killing themselves? They might. So you need to make sure that your nurses are educating them on how to do all the diabetic supplies, how to use it, how to inject insulin, how to drop the medications, etc. You have pens, which are much easier than syringes and vials to use, but pens are a lot more expensive. Can they afford it? Do they have insurance? Maybe they don't. Maybe they're homeless. Maybe they don't have a fridge to store their insulin in at home because they're homeless or because they live in a group home, things like that. That's very real world problems that people have with diabetes. So, that's all things you have to consider when you're talking to someone in the hospital before discharge. What follow-up they're going to have? Are they going to call to a nutritionist? Are you going to refer them to a nutritionist or a dietitian? Are they going to establish their primary care doctor? Do they need to see endocrinologists? Do they need to see nephrology? Do you need to put a referral in for ophthalmology for them, etc.? I mentioned the resources to store medication and affording. Diabetic education, nurses and classes. Most hospital systems have that resource to help patients. So you have to make sure that they're plugged in for that. Again, support system at home. Do they have someone to help them? Do they have even transportation to get them to their follow-up visits? Do you need to get case management involved to help make sure that they can actually get to their visits so they can control their diabetes? All things to think about. Let's see. Let's answer some of these questions. I'm assuming that the non-red labs mean normal levels. Yeah, I just highlighted some of the more critical ones. Why is the A1C normal if he had DK? It wasn't. He had like 13.8. That was really high. Since potassium is also responsible for hyperpolarization of the nervous system, would the nervous system be affected as well, since you mentioned potassium levels are low? Yeah, absolutely. The only thing I know is K plus inside the cell. Yeah, that's it. Yep, these are prereqs. They're called prereqs for a reason. Let's see, how often can type 1s get diabetics in his lifetime? I mean, just as much as anyone else. It depends if they're actually taking their medication or not. Do you send your patients to an endocrinologist? I'll usually send my type 1s to an endocrinologist. I think that's pretty widely accepted that endocrinologists, not primary care, are going to generally manage the diabetic type 1s. I have type 1 diabetics in my practice. I don't specifically manage their diabetes as well. Type 2 diabetics, I generally don't, unless I'm having really resistant, they're actually diabetes, they're actually doing everything, they're taking all their medications, they're doing everything, and they still can't get their diabetes under control, then I will ask an endocrinologist for their help. But generally, no, I don't send mine to an endocrine unless I'm having a problem. Can home insulin treatment lead to low potassium levels? Yeah, absolutely can. That's why, if someone's on insulin, I make sure to give them a handout on high potassium foods to make sure that they're incorporating that into their diet as well. So do you ever ask if people feel safe at home? Yeah, that's part of a standard workup. Usually the nurses are asking that. Every time someone comes in, that's something you'll ask, especially at something like an annual physical, you always ask that. Like if they need assistance, do they feel that they have someone reliable to assist them? Yeah, and if they don't, there's always things like home health and other agencies that can help people with their chronic conditions. Yeah. What do you do if an individual doesn't have these needs, like a frigid home, etc.? Yeah, that's tough. That's really tough. And sometimes you can't solve those problems, and sometimes you can fight for someone to get insurance and get them help. But sometimes you can't, and that's just the reality of medicine. Maybe you can make sure, if you can't do insulin, you can really make sure that they understand that they need to change their diet. And maybe you just have to go on oral medication. And sometimes you just have to accept that people aren't going to be as well controlled as that you like them to be. That's just the nature of it. What would you do when things don't go as planned? Things never go as planned. It's very rare that things go actually as planned in any regard. So you just have to adapt. Again, build rapport with the patient, see them back frequently, get their support system on in with you. You can't alienate patients. You have to build that connection so they feel comfortable with you, so they trust you, so that they believe you, so that they actually follow your recommendations. I mentioned we still have some time, but I want to mention some other things about the prereqs, the pre-med stuff. I mean, there's other things, not just diabetes related, that are important. Physics. You may decide you want to be a radiology. I can't even begin to tell you because I'm not a radiologist, but I know from friends who do radiology how much physics are involved with becoming a radiologist. MRIs are all magnets. So knowing your magnets, knowing your circuits, knowing your wavelength stuff for ultrasound. I mean, these are all things that, again, you may not be doing to the same level of general physics that you do in college as a radiologist, but that basis of knowledge will come into play there. I mentioned like general chemistry stuff. You may decide that you won't go become a physician. You might be a nurse, you might be a PA, you might be a pharmacist. We titrate medications. I know you heard that word titration for your OChem, GChem people. You may need to mix medications at different concentrations. If someone's on insulin that's called U100, they need a certain X amount of units that they take. But if someone's on U500, and it's 5 times as concentrated, you need to alter how many units they're taking. So knowing your concentration levels and just being familiar with those terms, again, all come into play. There's so many other things. Knowing how to stabilize, we talk about nerves and myelin sheaths on peripheral nerves and just nerves in general, and knowing what medications and what disease processes can impact myelination. Say you want to become a neurologist, and you're dealing with, someone like, I can't control someone's peripheral neuropathy with their diabetes, so I'm sending them to a neurologist to get better recommendations on how they can get help, knowing how the electrical pattern and works on nerves. Again, all of that comes into play. So many things that you're doing as a pre-med in your prereqs in college do form the basis for a variety of different specialties that you come into contact with or that you may go into in healthcare. Again, if you're a pharmacist, you're going to be making meds, you're going to be compounding medications. People in OChem right now, you do compounds, right? As a pharmacist, you're going to be doing that. You're sitting in the clinic on the first floor by the lobby check-in desk, and you're behind the desk while some people are picking up their medications, and you're mixing medications and stuff like that. You may work at CVS or whatever and do that. That's all very relevant. So it's crazy. It's crazy how much all of that is involved. We have a little bit of time before I get into that. Let's talk about a type 1 pediatric, right? Someone comes in, a kid who's say 5, gets diagnosed with type 1 diabetes, because typically how people will get kids will get diagnoses, they end up getting very, very hyperglycemic, and they end up in the ER in the hospital. That's a very, very common reason as to why kids will find out for the first time that they have type 1 diabetes. So, a 5-year-old is not going to manage his own medications, is not going to manage his own insulin, because he's probably a type 1. Those oral medications that help regulate insulin aren't going to work, because as type 1, you're not even producing insulin to begin with. So you're going to need to be on insulin. So who's managing that? Do his parents understand how to give insulin? Do the parents understand, you're going to have to stab your kid with a needle to check their blood sugars and give them insulin? Are they homeschooled? Do they go to a public school? Do they go to a private school? Does the school nurse, if they're a school nurse, who's going to give them their insulin at school? Who's aware, who has rescue insulin? All this stuff at school is all things to consider. You treat them very similarly, kids, when they come in with hyperglycemia in the hospital. You're giving them fluids, you're giving them insulin, etc. When you discharge them, they have to make sure them and the family understands everything. And that's very different for, say, a 5-year-old or a 6-year-old versus a 13-year-old, right? You could have a 13-year-old who's a teenager that comes in with this. And it's important because teenagers and they can be difficult. You have pediatricians who will deal with this stuff, but you also have a fellowship after pediatrics called adolescent medicine. There's a lot of people who do that because they want to get involved with just teenagers. They want to help teach these kids and these teens how to manage their own medical problems, how to understand their own thought, because it gives them some, as kids grow up, they want some level of control. They want to be an adult. They want to have some independence. So making sure that they understand their disease process and how to manage their medications and manage their blood sugar checks and everything is a really big thing of adolescent medication. So that's something you're interested in. You can go into that and really impact a kid's life forever. Someone who's type 1 diabetic at the age of 5, all right, they may have 75, 80, can you imagine 80 years to live with type 1 diabetes? And if you can educate them for the rest of their life and teach them as a kid how to manage it, you may prevent them from having problems for the rest of their lives for decades to come, longer than you're even alive. It's a pretty significant impact that you can have on people's lives. As a pediatrician, dealing with kids with type 1 diabetes. So it's pretty cool. Do you have a relationship with the nurses you work with, and how much do you work with them daily? Constantly. Every single patient, I work with them, nonstop. That's always something that, it's a team effort. Your pharmacists, your diabetes education nurses, your CMAs, you're always working with these people nonstop. We'll be sure to avoid these physics heavy specialties. Yeah, no, you're not wrong. That's why I did. How do you deal with the unprofessionalism in healthcare among clinic and clinical staff? Yeah, it's a thing. That's something, administration has to deal with in any hospital setting, whether it's on the nursing side or physician side. And I mentioned, talking to these patients have their own agendas, and you may be pushing for your agenda, and they don't like what you're saying. They don't want to do it. And then they're starting to yell at you, and they're yelling at the nurses, and everyone's upset. They lodge a patient complaint against you, things like that. I mean, that happens, unfortunately. It does. So you have to know how to manage that. It's tough. I don't want to give any MCAT advice because, as I mentioned before, I think it's been revamped and changed twice since I've taken it. So I don't know anything about that anymore, other than I know at my time review courses were very helpful. So that's something you guys can look into. Do advice for balancing or trying to maintain a good GPA. You're in the same boat as everyone else, so just work as hard as you can. Learn to prioritize. Don't do so many extracurriculars that you can't focus on your grades. You just have to figure out the balance that's good for you. So, talk to friends, get tutors, have some self-insight to know that what I'm doing is not working and how to change things, etc. I know it's off topic. I know some doctors work at clinic and others have their private office, but some do both. I'm confused at how that works. You can have a private group who works in your own private practice, but your group contracts with the hospital. So sometimes you work in the clinic, but you're also rounding in the hospital. And that's very common as well for private practices. What are the benefits to being a DO versus MD? You do a lot of, like you mentioned, musculoskeletal manipulation at the DO training. Yeah, I think at some level that's really great because it lets you get very comfortable with talking to patients, touching patients, doing physical exam, etc. So it does give you some level of comfort that you may not get in an MD school, but generally they're totally equivalent. There's really no difference, in my opinion, at all. If someone has a history of congenital kidney disease and hydronephrosis, are they at higher risk? Yeah, absolutely. Those people will be managed with a nephrologist in general. They probably were managed by a pediatric nephrologist at birth, and then they will transition to an adult nephrologist. So you're co-managing those patients very closely, but they are at higher risk, absolutely. I heard that diabetes can be passed down. It's not that it's passed down, but there's a genetic component, right? If I say, or I talked to someone, they were like, yeah, my dad, my mom, my grandma, my uncle, my aunt, my granddad, everyone has diabetes. Well, you're probably going to get it, right? And my goal at primary care, if you don't have it, say that person has pre-diabetes, my goal isn't to necessarily prevent them from getting diabetes. They're probably going to get it, right? There's only so much you can do to fight genetics. But if I can keep them pre-diabetic as long as possible before they actually hit diabetes, that's my goal. I was told once and by a number of different people, a new diagnosis of diabetes is the physiologic equivalent of having a heart attack. Diabetes is not good. Yeah, it's not as exciting as someone coming into an ER with a stroke or a heart attack. And now that's not exciting. I don't like to say it like that, but there's not usually a huge to-do moment with it. So I know it's not as glamorous to deal with diabetes on a day-to-day basis, but it's definitely important. And if we can keep people from becoming diabetic, that's a big thing. What kind of research internship do you prefer while in undergrad and in grad? I started with like some bench work with fruit flies. It was awful. But I ended up doing clinical ultrasound at a medical center related to, or that was attached to my undergrad, which is really cool. So ideally clinical research, if you can do it. I know it's hard in COVID times, but generally that's cool. That would be awesome. Do you practice OMM often or not really? Not at all of it. Can you talk to us a bit about DO school who are interested in applying? Yeah, I mean, it's med school. Med school is med school is med school. To me, it doesn't really matter. I think in the olden days, 10 plus years ago, it used to be that you didn't need as high of a GPA to get in. But I think it was the year I applied. I know my osteopathic DO school, the average GPA to get in was higher than 90% of DO schools. I think some of the Ivy League schools, the average incoming class GPA was lower than my DO school. And that is definitely increasing or changing now where that you need a lower score to get into a DO school. That's not a thing anymore. So there used to be a lot of bias that DOs aren't as good because they weren't as smart, they couldn't get into an MD school. That's just not true. At all. Yeah, you do some level of osteopathic manipulation. I think in general, from what I've experienced with some of my friends who went to MD school concurrently at the same time as went to DO school, they tend to have a little more emphasis on research that I think generally DO schools have. But in the end, it doesn't matter. If you're going to treat someone's diabetes, they don't care if you're a DO or an MD. If you're ER and you're going to pull a bullet out of someone's chest, they don't really care if you're a DO or an MD. So to me, it doesn't matter. If you're going to apply widely. Apply to the Caribbean, apply to DO school, apply to MD school. Doesn't hurt. You can always say no to whichever one you don't want. But I had a lot of friends and I knew a lot of people who had the best GPAs, 3.8, 3.9 GPAs, and they couldn't get into med school for years because they said, I'm smart, I can get into a really high fly school, I don't need to apply broadly, and then they don't get in. Well, tough. Now I'm a few years ahead of you now because I applied broadly. So, my recommendation is you apply as many places as you can afford to apply. Let's see, why did you choose family medicine? Schedule was a big thing. I was originally going to go into ER, and at some point during med school, I decided, you know what? I don't want to work nights for the rest of my life. I don't want to work weekends and holidays for the rest of my life. I want to have that 8 to 5 weekday lifestyle. So that was a big one for me, and I like the more complete care. I love ER. I still do a lot of urgent care stuff, and I did a lot of ER in residency and in training. I love that aspect of medicine, but that's not what I just wanted to do. And as family medicine, it gives me some aspect of that in an urgent care setting. But it gives me a little bit more as well. Is there a pay difference between MD and DO? Not a bit. Why did you ultimately decide to go to a DO route? Because I didn't get into an MD school. And I'm happy I did get into this DO school, and it helped me get to where I am now. So I have absolutely 0% regrets at all. Does diabetes affect the liver? Yeah, absolutely it can. Especially if someone's too obese and they gain a lot of weight and then they have fatty liver disease. And yeah, absolutely, that can happen. So I know there's a lot more questions. I probably have to end it here because I have to get ready to go to work. So thank you, everyone. I hope I answered some of the questions. I hope that was helpful for you, give you an idea of how primary care deals with diabetes, a little bit of education on what diabetes is itself, and how many things can be affected by diabetes, as well as, helping you to realize just a tad how important it is that what you're doing now. So keep it up. You guys are all doing great. You'll all get there. Don't worry. And I'm going to have another talk again in a month. So I will see you all then.
Thank you so much, Dr. Mittal, for another wonderful presentation. It's always a pleasure to learn from you.
Yeah, of course. No worries. Thank you so much. Let me stop sharing the screen.
Everyone, make sure to check out his socials. His Instagram is Mit.
Additionally, thank you all so much for attending. The link to the Google form has been posted in the comments, and it's also about to be in our Instagram right now. So please make sure you fill it out within the next 30 minutes for us to receive verification of your attendance. Again, thank you so much, Dr. Mittal. It was a pleasure to learn from you.
Thank you, guys.
Thank you so much.
We look forward to hosting you again.
Have a good day, everyone.